Well, I think that that is one of the most exciting parts about our work for me is that we are looking at a completely different mechanism for treating depression. You know that when you witness a person receiving a ketamine treatment, an infusion, we very typically see an antidepressant response, a lifting of the mood very quickly, really within hours, sometimes after the treatment is complete.
You have found the Thinking Mind podcast. This week it's Anya, and I've got the joy of speaking to Dr. Lawrence Park, who is a psychiatrist and the current medical director of the clinical research unit at the National Institute for Mental Health in the United States. Through this role, Dr. Lawrence Park has headed up a huge number of ketamine studies. So in this episode, we talk mostly about ketamine, and specifically about ketamine as a potential treatment for depression. I hope you enjoy, and as ever, let us know what you think. So we're really excited to welcome Dr. Park onto the podcast to talk about all things ketamine. Dr. Park, welcome.
Thank you, Anya. I really appreciate the invitation.
Thank you very much for joining us. We're very lucky to have you. So, Dr. Park, I'd love to start us off by asking you if you could tell us a bit about what research problem you're currently focusing on, or perhaps what excites you in your work at the moment.
Absolutely. Before I launch right into that, I did want to give you a little bit of background in terms of who we are and what we do.
Please.
So at the National Institutes of Mental Health, I belong to a lab that's called the Experimental Therapeutics and Pathophysiology branch. And our principal investigator is Dr. Carlos Zarate. And Dr. Zarate has been at the lab about 20 years, and he has conducted some of the very initial clinical trials on intravenous ketamine, and has really been the guiding force for our lab since that time. So, and I definitely want to give a shout out to him. At our lab, it's really our primary mission to explore and develop novel and rapid acting pharmacological treatments for depression and other treatment resistant mood disorders. So that's really what we do. And since 2006, when Dr. Zarate did that initial ketamine study, we have been continuing to do other ketamine studies. We're ever trying to improve the treatment, learn more about how it operates, and really explore the underlying biological mechanism for how ketamine works for depression. So that's really what we're trying to understand better. A word about research at the intramural program at NIH. So we are government funded, we're a part of the government, and as such, we really see it as our mission to perform early stage, riskier research that many other researchers might not undertake. Industry probably would not undertake it given the risks of failure. Academic and independent researchers also might shy away from this sort of research because of the difficulty in terms of getting grant support. So, we see that as our niche in terms of doing research, is doing the riskier research given, the government funding that we have, and hopefully creating new ideas, new conceptualizations that other researchers can build upon. So that's really our goal at NIH.
That sounds really cool. What kind of things, when you say riskier types of research, what kind of things does that involve?
Well, for instance, I mentioned that a lot of our lab's activities began with looking at ketamine. But we have also looked at a lot of other potential compounds that have other experimental or conceptual mechanisms of action that are not typically related with antidepressant response. So we don't study typical monoaminergic systems of treating depression. Ketamine, as you might know, does not work on a monoamine system of response. At least we don't think it does. We think that the primary mechanism of action is through the glutamate system. And so glutamate is, a very different type of neurotransmitter than the monoamine systems. It's the most prominent excitatory neurotransmitter in the central nervous system, and therefore pretty widespread. And so it, works by a completely different mechanism. We are looking at other drugs that might work by a similar mechanism. We also look at other drugs that work by different mechanisms as well. So we've done a number of trials in the past 10 years. We've done a lot of failed trials as well. So there are probably 4 or 5 different neurotransmitter systems we've looked at that really have not panned out. And so that's what I mean by we're looking at doing exploratory research that other people might not undertake.
I guess to take you to what you were talking about with the mechanisms of ketamine, I mean, so for me, ketamine was one of the very first things that I remember hearing about in my neuroscience lectures in relation to psychiatry treatments, close to, sort of 5-10 years ago. And it was incredible because here was this drug that people were telling us in the lectures would act in a completely different way to your usual antidepressants. So you've mentioned the monoamine system, so your chemicals in your brain that are thought to be linked to mood, so things like serotonin or adrenaline that people often talk about, and your common antidepressants, Prozac, fluoxetine, citalopram, sertraline, things that a lot of people might have been on, work on all of those. And then here's this drug that acts in a completely different way. But not only that, it helps people potentially within hours and makes them feel better on the day rather than having to wait a couple of weeks until they have some kind of treatment effect. So my interest was obviously piqued immediately. And it's a drug that's being considered not just in depression, and I think you've mentioned that you work a lot on affective disorders generally. I think in bipolar depression, it's starting to be looked at a bit as well.
Yes. And
in other illnesses, drug dependence type areas. But I guess I'm aware that for all my excitement, the story is not necessarily that straightforward. And I wonder, I guess, where do you feel that things are at with ketamine at the moment?
Well, I think that that is one of the most exciting parts about our work for me, is that we are looking at a completely different mechanism for treating depression. You know that when you witness a person receiving a ketamine treatment, an infusion, we very typically see an antidepressant response, a lifting of the mood, people's cares and worries evaporating very quickly, really within hours sometimes after the treatment is complete. So, that's very different than the type of response that you would get with conventional antidepressants. So what excites me is that with the monoamine theory of depression, I was always left a little bit underwhelmed by, what it meant in terms of understanding depression, understanding the ontology of depression and how it comes about and how it is experienced and how it fits into people's lives. But when we look at ketamine and we, understand it to have some sort of glutamatergic activity, the prospect of coming up with a more complete story about depression and how people's emotions play into their lives and how they are impacted by things that happen to them, that really comes into a little bit more focus. So, for instance, I mentioned that glutamate was a very prominent neurotransmitter system, and it is. And we know that it is related to a lot of different important functions, things like neural development and learning and memory, in addition to emotional regulation as well. And then also related to different aspects of neuroplasticity. And, when we talk about neuroplasticity, a lot of people bring that term up or that concept up as, a magical black box. But, really what it is changeability, the changeability of the structure and function of the human brain. And we know now that, even in adults, we see that, and it's necessary. It's necessary for things like incorporating experience. It's necessary for emotion. It's necessary for encoding memories. So the brain needs to change in order for us to be able to have these sorts of functions. And when we think about depression fitting into that, one of the ways to think about that is that people have experiences, and some of those experiences are stressful or negative to the point where they may alter or change the structure and function of the brain deleteriously, so that depression might result. Mm-hmm. And if that is the case, and when that does happen, people become depressed. Sometimes that can be changed by different treatments, such as conventional antidepressant medicines or psychotherapy, or changes in psychosocial context, or other sorts of interventions. I don't want to suggest that only medications or biological treatments are efficacious. And when that happens, for a lot of those treatments, we have evidence that when that happens, you actually, for depression, what you see in states of depression is that the structure of the brain changes such that you may see pruning of dendritic trees within the neurons, decreased connections with other neurons, decreased synapses. And so that's the depressive state. And when that is adequately treated, you can see the normalization of those deficits happen. So the exciting part for me with ketamine is that it taps into this story of understanding how all of these different things are related, not just biological aspects, but also environmental and social aspects of human life.
What is it like when someone receives ketamine?
Yeah, so we do have a number of protocols right now where we are administering ketamine infusions intravenously. There are a number of different ways that people can receive ketamine. It's on the market. It's been on the market since the 1970s in the U.S. for anesthesia. When we use ketamine, we do it in a very controlled and formulaic sort of way. So we always give a standard dose of ketamine, 0.5 milligrams per kilogram, and we always infuse intravenously over 40 minutes. So that part of our methods are always the same. I just want to put that out there in front because, now there are a lot of ketamine clinics in the United States anyway that are they're administering ketamine off-label to people that have depression, but they're doing it in very different ways. So depending on the routes of administration or the amount of administration and the speed of administration, you can get different sorts of reactions. But I'm telling you about what we see in this very standardized way that we deliver the treatment. So when we deliver the treatment, we usually do it in a very quiet room with a minimum of people, patient lying on the bed. We actually usually place 2 IVs. One is for the treatment, and one is also to collect blood samples for our research. And when the patient is ready, we dim the lights to try to reduce stimulation, and then we start the infusion. We just use a typical infusion pump and program it so that the infusion will go in over 40 minutes. And again, the dose is personalized for each patient. So it's 0.5 milligrams per kilogram. And so for any particular person, that might average between 50 to 100 milligrams of ketamine. So during the infusion, we usually see typical types of side effects that come up. The first is that people may or may not get a little bit sleepy or sedated. And then after that, we often see dissociative symptoms arise. And when I talk about dissociative symptoms, I'm really talking about people feeling disconnected, either disconnected from their surroundings, disconnected from their emotions, or disconnected from themselves. A lot of times people will be very slow to respond if you talk to them. They may feel like distances are distorted, so that people might feel like you're 100 miles away, or they might feel like you're, extremely close to them. They might feel like parts of their body are either elongated or short or missing. They might feel like they're outside of their body, or that they've sort of lost a sense of themselves overall. So it can be any sort of range of that type of symptom. Some people experience that as a pleasant type of experience, and some people really don't like that experience at all. So that is dependent on the individual. So, and usually that is maximized during the time of the treatment. And after the treatment is over, those symptoms will resolve usually within an hour or two after the treatment is done. The antidepressant effect, the lightening of the mood and the relief of anxiety, that usually happens a little bit after that. So we begin to see a peak in the antidepressant response at about 2 hours afterwards. And that grows until 24 hours. And at 24 hours post treatment is when we see the largest response. About 70% of people who receive the treatment will respond to ketamine at the 1 day mark, at the 24-hour mark. And then after that, if a person only gets one treatment, then that response will slowly taper off to where it's not significant within 3 to 7 days.
I mean, one criticism that I've heard, or I guess maybe not criticism, but concern about that immediacy of the response and then the speed with which it decreases is, how can we know that it is a antidepressant response rather than some kind of euphoric drug effect? You know, you've just given someone a bit of a good trip or a cool experience and they feel better just because of that. But then the instant that fades away, actually they're just back to being depressed.
Well, yeah, that is a criticism that is out there. First thing I would say is that if you do witness a treatment, it will seem like the acute effects, the dissociation and sedation, and all the other effects that are related to the infusion per se, they do seem to be separated from the antidepressant effect. So I mentioned that those acute effects happen right during the time of the infusion. A lot of times people do not say they feel better during the infusion. It's only 2 to 4 hours later that antidepressant effect starts to take hold. And so that would be one of my responses, is that when you actually watch a person have the infusion, they do not seem related. The second thing I would say is that, of course, that is a concern it should be a concern for all of us, how long that response lasts. But people have been working on trying to extend that response as well. And one of the ways that people have been trying to do that is by giving repeated doses of ketamine. And also with the development of intranasal S-ketamine, that also is indicated for repeated dosing over time. And what we do see with both of those applications is that with repeated doses, you can actually prolong the effect of the medication out to several weeks and maybe even several months after the course of the treatment is completed. So not unlike ECT, electroconvulsive therapy, you can see that with a maintenance program, you can actually prolong the effect of the treatment over time. We still have a problem, though, because that effect does not seem to be permanent. And so even after a few months, the positive treatment effects start to go away again, and we're left in the same position. So, I mean, that is a challenge for the future.
Given what you've mentioned about the potential effects on learning, memory, is there any work on combining the effects of ketamine with some kind of psychotherapy, so to try and maintain the effects with making use of that potential for learning new experiences or changing people's view of the world?
Yeah, there's a lot of interest in this idea of combining different treatments. You mentioned combining with psychotherapy, and that strategy, you probably see that strategy a little bit more in some of the research that's going on now with psychedelic agents, but that has been tried a little bit in ketamine as well. What I would say is that I think it's too early to say whether that's going to be a fruitful way to look at it, but that's the idea. The idea is if you can change something about how people are learning or incorporating memory, you might be able to put them in a position or a state where they're more likely to be able to take up something like psychotherapy and have that be more useful for them. So that idea is out there, and that there are studies going on like that. For ketamine especially, I think it's a little bit early to tell whether that's going to be a successful strategy.
Okay. And in terms of depression as it's being treated, my understanding is mainly so far it's been unipolar depression. But is there any work or what's the kind of feeling about if it might be useful in bipolar depression or bipolar illness generally?
Sure. Yeah. So the couple things to say about that. One is when Dr. Zarate did those initial controlled trials in the early 2000s looking at unipolar treatment-resistant depression, he also did a series of studies looking at bipolar depression. And he found a very similar response curve where you see improvement starting within several hours after the infusion is done and peaking at 1 day, and then lasting out to 5 to 7 days. So you see that very similar type of response with bipolar depression as well. One of the things that people have been concerned about is whether it would induce hypomanic switching. And at least in our experience, we have seen in all of our studies, we've actually seen 2 cases of switching. One was when a person was receiving placebo, and one was when a person was receiving active ketamine. So, I mean, it's really not enough evidence to say one way or the other. I think we have to be on the lookout for the possibility of switching, but at least our experience so far doesn't suggest that it's going to be an active type of adverse event that we, really have to be careful of. Having said that, however, there's not a lot of evidence that ketamine is good for the manic or hypomanic phase. So I think it's not likely that it's going to be a good treatment for manic conditions. We have looked at other subtypes of depression. There's some literature looking at other diagnoses as well. And at least from our work, we find that people that have anxious depression and anhedonic depression seem to respond very well. A couple of years ago, we did a post hoc analysis of our data looking at atypical versus typical symptoms. And it appears that ketamine is almost as effective on atypical symptoms as it is for typical symptoms. And it also seems to have very good efficacy for suicidal ideation. So those are the types of associated symptoms of depression or subtypes of depression where we see ketamine having a good effect.
So many things from what you've just said that I want to ask you more about. Just to signpost some of our non-psychiatry listeners, so when we talk about switching, that's what the phenomenon we mean is in people who have a bipolar illness. When they are given an antidepressant medication for a depressive episode, what can happen is that switches and they then very quickly go into having a hypomanic or a manic episode. And then I wonder, when you talk about atypical versus typical depression symptoms, what kind of things did you find ketamine seemed to be helpful for?
Right. So when sometimes this is a very old distinction within depression, the idea of typical or melancholic symptoms versus atypical symptoms. So when we think of kind of our typical melancholic depression, we are thinking of a person that has very depressed mood and problem sleeping and anorexia, not feeling like they want to eat, lack of interest, lack of motivation in things. And somewhat, distinct from that is this idea of atypical depression. So atypical depression seems to constitute a different group of people where they may feel depressed, but maybe, not as prominent depressed mood as melancholic depression. In fact, a lot of times atypical depression is linked with reaction sensitivity or having more of a reactive mood than depressed mood. And in addition, not having problems with sleeping, but having problems with oversleeping. So being hypersomnic and also not being anorexic, but actually eating more rather than less. So, very early on, it was noted that there were sort of these 2 different ways that depression might manifest. And, thus they were sort of classified as typical or atypical. Now, when we give ketamine for either of these groups or either of these symptom constellations, what we see is that ketamine seems to have effectiveness for both groups. And that is different than our typical antidepressants, our SSRIs or SNRIs. The problem with atypical depression is that it's very difficult to treat and a lot of times is resistant to our standard treatment. So if we find a treatment that can be equally efficacious for both types, then that's a good thing. So then we can treat any type of depression.
And you mentioned suicidality. And I mean, this is one bit that I think is really, really fascinating about ketamine because, I mean, again, I guess rather than like atypical depression, we don't really have good treatments that act on suicidality or, that feeling of sort of deep despair and hopelessness that people can get into, particularly given that our antidepressants take time to work, but perhaps also because those thoughts of suicide and suicidal plans are something slightly separate. What can ketamine do for suicide, or what does it seem to help with?
Yeah, so we're excited about its possibility of use in people that have suicidality as well. Along with those initial studies looking at treatment-resistant unipolar and bipolar depression, there were also a series of studies done looking at suicidal ideation. And independent of ketamine's antidepressant effect, it was also found that ketamine had a very significant anti-suicidal effect as well. And no surprise, it followed the response curve as the other depressive symptoms that we were looking at as well. A couple of caveats here. One is that patients that enrolled in the studies where we were looking at treatment-resistant depression, in general, they were not the most severely suicidal patients. They were allowed to have some level of suicidality, but if suicidality, was so prominent that they were really at risk of injuring themselves, then they would not have enrolled in the study. So I think it's important to note that, we're looking at suicidal ideation, but really within, a narrow band of what suicidal ideation might be like, and within the sort of milder manifestations of suicidal ideation. And the other thing I would say is that this was a post hoc analysis as well. So we were looking at measures that we had for suicidality that were sort of built in to the measures we'd already gotten. So the suicide item on the Hamilton Depression Rating Scale, or the suicide item 10 on the Montgomery-Asberg Depression Rating Scale, were the outcome measures that we used. And so it's only one item. And, it's a good item to look at, but it wasn't, of the full range of the suicidality that you might see in the clinic. Still, we did find a very potent anti-suicidal effect. And actually, a meta-analysis that came out by Wilkinson in 2018, I believe, looked at all of the studies in the literature that looked at its effect on ketamine's effect on suicide. And that positive effect played out throughout the literature as well.
It must be quite a difficult thing to study, both in terms of, like you mentioned, the challenges in recruiting safely, so recruiting people who might be having the milder end of symptoms, but also because how do we know if the thought will lead to the action? How have you navigated? I don't know. Have you got studies that are looking specifically at suicidality at the moment, or is it still just within the complex of treatment-resistant depression that it's studied for now?
Yeah, absolutely. I think that that's one of the challenges that we have, not only we within our group, but we as a profession. A lot of times when people do studies on depression, one of the exclusions for study participation is acute suicidality, which is unfortunate because it's actually that population of patients that probably needs the most help in terms of finding new treatments. So, we would make a strong argument that studies should not exclude people with suicidal ideation as much as they're able to. And, Dr. Zarate has made it an important priority for us to be able to study people that have any level of suicidal ideation, even to the point where they've almost attempted or they have just attempted. So we do actually have an ongoing study right now, and it's conducted by my colleague, Dr. Elizabeth Ballard. So she's our suicide expert, and she's running a study right now that is attempting to understand the differences in sort of long-term traits versus acute state differences in people who are suicidal and who are not suicidal. And as part of that study, there are some groups, acutely suicidal groups, or just post-suicidal groups that we would administer ketamine to and to see what the outcome would be. So we are trying to do that. I think that it's relatively easy for us to run a study like that because we have a controlled, closed setting where people would be contained. We have a lot of professional staff that can really support patients during that period of time. So it's feasible for us to do that type of study. And again, we should be doing the risky, more difficult research. But I would also, make the argument to other people that, not only at the NIH, but, throughout the research community, psychiatric research community, this really should be a condition that we should be studying more.
And do you have a sense for if ketamine might be helpful for suicidal thoughts just in patients with depressive illness, or if it might be something that might have benefit in other psychiatric illnesses?
Well, to this point, the large body of evidence are people that are depressed. But, that's a very interesting idea. And, what you bring up is true, which is that suicidal ideation is most often associated with depression, but it's not always associated with depression. It can be also commonly associated with overwhelming anxiety or obsessive compulsive disorder or psychosis. So there are a lot of different potential diagnoses that might be in play. We are trying to get away from this idea of sort of diagnosis-based research. But having said that, our main diagnostic groupings that we focus on are unipolar and bipolar depression. So that is primarily the group that we're looking at. I don't think there's enough data yet to say whether ketamine has an anti-suicidal property outside of that, but I think that's one of the important questions to ask in the future.
And I wonder if I could ask you about S-ketamine and how it might differ from ketamine, and I guess what your thoughts are on S-ketamine as it enters the market.
Yeah, so, S-ketamine is a form of ketamine. It's the S enantiomer of ketamine, which is one of the mirror images that is naturally occurring for ketamine. And, initially, when they were looking at the two different enantiomers, the S and the R-ketamine, they found that the S-ketamine had greater effect at the NMDA receptor. And ketamine is an NMDA antagonist, meaning it blocks its effect at that receptor. And initially, we thought that was, really probably the primary mechanism of action of how ketamine works. Now, we're not so sure about that. But, at that time, that's what they went with, and that's why they focused on S-ketamine. So they looked at S-ketamine. There were some initial intravenous studies, but then the company that developed it developed intranasal formulation. If you look at those studies, so there were two pivotal trials, a short-term trial and a long-term trial looking at S-ketamine in addition to standard antidepressant treatment. So it was looked at as an adjunctive treatment. And it demonstrated good effect in the short term, significant effect, and it also demonstrated the ability to maintain the effect over time. I think they looked at maintenance treatment using S-ketamine for people that responded initially out to 80 weeks. So that's like a year and a half. And they didn't find that everybody remained in remission or responded, but the amount of people that responded in S-ketamine was significantly greater than the placebo arm. So based on that, that was the reason for the FDA approval. So S-ketamine has been on the market in the US a couple of years now, but there are a couple of things that limit its use. The first issue is that while it's on the market, as often happens in the United States, it's not covered by insurance companies yet. So a lot of times it's not available to people unless they want to pay out of pocket for it. So that's one of the difficulties with getting S-ketamine treatment right now. The other is that when the FDA approved S-ketamine for treatment-resistant depression, they were concerned about the dissociative symptoms, and they were also concerned about the potential for abuse and dependence. And as a result, they placed it under a program that they call the Risk Evaluation and Mitigation Strategy, or REMS program. And the REMS program really requires that the S-ketamine treatment not be done at home, but be done in the office under the observation and supervision of a healthcare professional. So the doctor, the healthcare professional, doesn't have to administer the treatment, but they have to watch the treatment, watch the patient doing their own treatment, and then observe them for 2 hours after the treatment to make sure that they're stable before going home. And so, of course, when you have to go into an office to do a treatment at least twice a week, then that also limits its availability to people.
And again, so like with ketamine, it's not a short-term one-off solution. It's still something that people have to take continuously for a long time. And you mentioned this, but the concern that I guess there's a few adverse effects that people get concerned with ketamine, but one of which being the potential for dependence or for people to become addicted to it.
Yeah, that's correct. So, that has always been a concern for any of these ketamine treatments, is the potential for abuse. And as we all know, ketamine is an illicit substance that is abused by people. It was abused by people long before we ever considered it as a treatment for depression. And it continues to be abused. So the question really is, does ketamine use, the way we use it for depression, which is actually different than how it's abused. The doses that we use for depression treatment are much lower than typically how it's abused on the street, and it's also much lower than how it's typically used for anesthesia. So is that type of usage predisposing to abuse and or dependence? And I think the answer right now is we don't really know. It's been, very early since S-ketamine was approved, and intravenous ketamine has been available for some period of time, but you have to remember intravenous ketamine is also not FDA approved, and it actually has very little oversight. So that's the problem with off-label use, is that nobody's really monitoring it very well. So there's not a lot of collection of data on the adverse effects of intravenous ketamine administration. That's one of the problems that we have. With S-ketamine, there is actually a database, a reporting database for adverse events. And actually, there was a recent report from 2020 about what those adverse events, what they were seeing with S-ketamine. I don't recall that abuse was actually on there, but one of the issues was that there was some question of whether S-ketamine, perhaps not unlike our standard antidepressants, might increase the possibility of suicidality. So I don't know what the answer to that is, but I think that's something that we're going to have to watch for the future.
Gosh, so in a different way to what we might see in the acute infusion effects with ketamine, S-ketamine itself over a long-term prescribing might actually increase suicidality, or there's some early reports of that as a potential adverse.
Right. Well, so no, it's not really clear yet, but correct. over and above the antidepressant and anti-suicidal effect that we see, there may be some, very small percentage of patients that may have some sort of reaction to S-ketamine treatment to increase suicidality in some cases. That's not unlike the situation where we have black box warnings for our SSRI treatments, especially for young adults and children that are getting these treatments, that there may be something about, that population of patients getting SSRIs. Perhaps it has a tendency to make them more agitated, and that may lead to suicidality. So it might be a situation like that. It's really too early to tell because it's only a couple years of data, and it's not controlled data. It's reports into an FDA database. So I think we have to continue to monitor and see how that develops.
One other thing that I remember it highlights being the importance of having monitoring were the concerns about naltrexone, an opioid receptor blocker, and it potentially taking away some of the antidepressant effects of ketamine. I'm wondering if that's a concern that still exists, or if we have evidence to the contrary now, or I guess what the cutting edge feeling is.
Yeah, so you might be referring to a study that came out a couple of years ago looking at the application of an opiate antagonist and that seeming to extinguish ketamine's effect. So, that was a very small study, first of all. But I think, people took that to heart and really, I know that Dr. Zarate in our lab are very interested in that because it suggests that, maybe part of the mechanism of action of ketamine is not through the glutamate system, but it may be through the opiate system. And so I think that we cannot discount the possibility of that. And so that really is an area that warrants further investigation. It may be that ketamine in whole or in part gains its efficacy through an opiate mechanism as well. And that's not the first time that we've thought about opiate mechanisms for depression. So, that's a very plausible possibility.
Because I guess it would make sense in that it is something that does make people in some way feel good. And if it was possible to separate that from the dangerous side of opiates, i.e. their hugely addictive potential, then that might be good.
Right, absolutely. And that's not our particular area of investigation, but that is a very active area of investigation for antidepressants.
And one other big adverse effect that people often mention to me as being an area of concern is the effects on the bladder. And I guess it is something when we talk about needing long-term administration of ketamine or S-ketamine.
Yeah, one of the main symptoms that people were seeing with anesthetic use of ketamine was cystitis and bladder problems. So again, that might be dose dependent. We have not seen that arise so much with ketamine administration for depression. And it very well might be because we're using much lower doses. But again, we don't have a huge amount of information yet about using ketamine for depression. So that's another good reason for wanting to, be very vigilant and keep a very good record, keep a very good database of adverse effects that crop up with ketamine or S-ketamine use.
What are your directions at the moment, or the things that you're excited about? I know you've mentioned some of them, but I wonder if there's anything that I haven't asked you about yet that you're looking forward to in your research work.
Sure. So there are a couple of things that we're working on that I would say are pretty exciting. You might or might not agree with me. One of the first things is, as you probably know, we don't have a biomarker for any sort of psychiatric treatment at this point in time. And, that puts us way behind other specialties. And more than that, it makes our job of trying to treat people much more difficult. But we're excited about the possibility of identifying a biomarker for ketamine response. And some of our earlier work conducted by our neuroimaging staff, Dr. Allison Nugent and Dr. Jess Gilbert, they have used a imaging modality called magnetoencephalography, which looks at the very minute changes associated with brain activity. And they have noted that, once you process the data in a certain way, so this isn't like, you can't go down to the drugstore and get this yet, but, once they've looked at the data that they've collected, they've noted that people with lower gamma power, the lower gamma waves that are recorded on the MEG at baseline, seem to be related to ketamine response. And when ketamine works and they respond to that, then their gamma power increases post-treatment, reflecting improvement in symptoms, versus a group of people that are depressed that have high gamma power at baseline. And those people, when they get a ketamine treatment, they're less likely to respond to treatment. So, our MEG researchers right now are really working hard to try to understand that more and see whether that can actually be developed into a viable biomarker that could be used on a clinical basis. So we're not there yet, but I think we have some really encouraging results that we see this distinction at baseline. So that's one of the exciting things that is going on now. And that would, represent the first actual biomarker that we would have for depression response or any response in psychiatry. The other is that, we've talked a bit about the downside of using ketamine or esketamine. So another strategy that we've been using is we're looking at other drugs or other compounds that may be able to reproduce the positive antidepressant effect of ketamine while minimizing the negative effects, the dissociative effects, the potential abuse that is associated with ketamine. So I mentioned before that we think that the glutamate system is in some part responsible for the antidepressant effect of ketamine, though we're not entirely sure how that works. Initially, we had thought that the blocking of the NMDA receptor was what was critical for the antidepressant response. And as a result of blocking that, there are a number of different NMDA receptors, within that neuronal system. But we thought that by blocking it, one of the effects would be to increase glutamate release into that synapse. Mm. So we looked at different ways that might be achieved by using other drugs. For instance, there was a drug that we had looked at that binded to the glycine site on the NMDA receptor to produce a similar type of effect. Unfortunately, that did not show the clinical effect, the efficacy for depression that we were hoping for. Mm-hmm. A trial that we're doing right now is looking at a different glutamate receptor called the metabotropic glutamate receptor, which we hope, again, would sort of reproduce that effect. And we're in the middle of that trial, so I'm not sure how, that's going to turn out at the end. One other area that we're somewhat excited about is looking at the metabolites of ketamine. So previously I mentioned that the positive effect of ketamine is not seen right when you give the ketamine or during the infusion, but really a couple hours afterwards. And if you think about it, if you wait a couple hours after the infusion, actually the large majority of the ketamine that was infused has been metabolized already. So there's no more ketamine per se circulating within the system. It's really a number of different metabolites that have been, ketamine is metabolized by the liver, and there may be 10 or 20 different compounds that come out afterwards. And so actually this was, Dr. Zarati's, I think, really brilliant idea was to take a look at the metabolites because they're contemporary with the antidepressant effect. And actually with some researchers at the University of Maryland, Todd Gould and his lab there, they actually identified one specific metabolite, 2R6R hydroxynorketamine. So that's one of the many metabolites of ketamine. Mm-hmm. They identified that compound as the compound that is related to antidepressant effect. Now, they did that in animals, not in humans, but it was, an undeniable result that it was actually this compound that seemed to be related to the antidepressant effect. And even better, they also found that that compound did not seem to be related to dissociative effects. So we have great excitement about that compound. It's actually in phase 1 testing right now for safety and feasibility. And we would hope that, maybe later in 2022, we would get that compound to do a real efficacy trial for. So that's one of the other areas we're really excited about.
That got me wondering, because there's been some discussion of whether the psychoactive effects of ketamine do have something to do with the antidepressant effect. And I think, there's something you've brought out some work on as well, looking at the link between the either dissociative effects or some of the subjective effects of ketamine and how they might relate to the antidepressant effects. What's your feel on it?
Yeah, there has been some work that's been done in that area, including by our group. There have been some conclusions that the dissociative effects might or might not be related to the antidepressant effect. I think, my understanding of how ketamine works is more along the lines that I just mentioned, where it may be possible to separate dissociative effects and antidepressant effects. So my belief and my hope actually is that they work by separate mechanisms. Now, with regard to the psychoactive effect, I know that you had asked a little bit about that before. So first of all, there is a body of research that is looking at the psychoactive effect and whether that may facilitate any psychotherapeutic effect that somebody might be doing at the same time. And I guess what I would say is that for ketamine especially, and I would also say this is true for the psychedelics, but specifically with regard to ketamine, I think it's way too early to determine whether that's going to be a successful strategy or not. So I don't know about that. The other sort of related question is, do psychoactive effects by themselves without psychotherapy, do they predict or do they even, say, mediate the antidepressant effect? There have been a few papers looking at that. Some of them actually positive, but at this point in time, what I would have to say is that there hasn't been anything that I've seen in the literature that has convinced me that psychoactive effects are necessary for the antidepressant response.
So hence looking at the metabolites or different chemicals could be a really exciting area that might make the translation to clinic much more straightforward if you can get rid of that 2-hour observation or all the things that you're currently having to do to keep people safe after receiving the treatment.
Yeah, we have our fingers crossed for that one.
Dr. Park, I'm aware I've taken a huge amount of your time, and I'm so grateful to you for everything that we've spoken about. Before I draw us to a close, I just wonder if there's any misconceptions about ketamine or indeed anything that I haven't asked you about that you would hope either to do with your work more generally or anything else that you'd like to bring out to a wider audience.
I guess in closing, I would just like to say that initially before I came to the NIH, I had some skepticism about ketamine being a viable antidepressant. And, I think mainly my ideas were based on the fact that it was a drug of abuse. And, people, of course, would want to use a drug of abuse and they might feel better from using that. But since I've been at the NIH and since I've taken part in these studies that we've been doing and, witnessed firsthand the type of effect that ketamine has, I'm convinced that ketamine has antidepressant properties that are completely independent of any of the sort of abuse potential, any of the side effects that people might be taking ketamine for. They do seem separate to me. And there is something independent about ketamine that really makes it a potent antidepressant treatment. So, that's the first thing I would say. And we're not looking to sort of advance ketamine as a treatment for depression. In a perfect world, we would love to apply what we've learned from discovering that ketamine is an antidepressant treatment, apply that knowledge to create an antidepressant treatment that is free of the abuse problems and the dissociative side effects and some of the other significant adverse events that ketamine is associated with. So from our perspective, that really is the goal of the type of research that we're doing. Finally, I just want to thank everybody in our lab, because the type of work that we do is really team science. At NIH, it's not just a result of one people or even a small group of people. We have a large group of people at NIH. We do multimodal research. We have clinicians working with psychologists, working with sleep experts, imaging experts, genomic experts. So we do research that combines a lot of expertises together. And so that work would not be possible without everybody in our group. So I just want to make sure that that we acknowledge all the people that work in our group and that are conducting this work.
That's a wonderful note to finish on. Thank you. I think there's only good things to be gained from recognizing that and working as a team, rather than the publish or perish culture that does exist in some industries, I guess, in some parts of research. So it's really cool to hear that that's the way that you guys work, and actually then to see the effects of that and the benefit that patients will hopefully see, and then the future vision for an antidepressant that is fast and hopefully free of some of the negative effects that ketamine might have is a really hopeful note. So thank you.
Well, we're really grateful for this opportunity to talk with you, and hopefully we'll have something to report more exciting in the upcoming year or two.
Absolutely fantastic. I mean, the pleasure is entirely ours. So thank you so much for coming to join us.
Sure. Thank you, Anna.
You are listening to the Thinking Mind podcast. Thank you so much for listening to this episode. If you enjoyed it, please share it with a friend or give us a rating. It really does help people to find us. If you find the podcast valuable, why not buy us a coffee to help keep us going? There's a link in the show notes. As ever, we love to hear from you and love to hear what you think. So drop us an email or get in touch on social media. Thank you so much.